Welcome to Living a Full Life podcast. Join us as we explore health topics that encourage raising healthy children, living a healthy life, and living the best life possible. Now, here's your host.
Welcome to another episode of Living a Full Life. I'm Dr. Enrico Dolcecore, and each and every week we drop you health and wellness tips for you and your family to live healthier, fuller lives by listening in, and we appreciate each and every one of you. This week's topic, GLP-1s. We're getting into weight loss season. You know what that means. New Year's resolutions, end of the year. It's actually sugar season, and I thought this was a perfect time to talk about this stuff because people actually start thinking about this now. This is almost the busiest time of the year for people thinking about weight loss. I think it's from a healthy perspective, from our perspective in the functional medicine and chiropractic realm, is that we get healthy, conscious people that are always ahead of the game. So they're not going to wait till January 1st for a resolution. They know it's sugar season. They're like, what can I do to stay out of trouble? And that's a great preventative way to keep yourself healthy. And I love it. So what a great timing for this. GLP-1s have blown up. I think Ozempic alone has doubled Denmark's gross national product. GDP. That's insane. It's like trillion. I think we're approaching trillions. Can you believe, with an S, on how much money this stuff has made, Ozempic, and it's, compounds as well. So let's talk about what GLP-1s are. And you know what I'm going to talk about? I'm going to talk about the physiology, how it works, what it does in the body. So you get a general understanding, because that's how I understand things. So I guess if you listen to my podcast, it's because we are on the same wavelength. If you don't, it's because I'm either way above your head or way maybe too dumb for you. I don't know, whatever it is. But the people who listen do appreciate it. And I try and keep it simple but educational each and every week. This might be one you want to share with people thinking about GLP-1s, semaglutides, on it, not on it, maybe had adverse reactions, whatever it may be. We're going to talk about this, diving into GLP-1s. They are a class of medicines that has exploded into everyday conversation. We'll explain what they are, how they work in the body and the brain, where they come from, even, yes, the history of the Ozempic story, how they should and shouldn't be used, and the risk patients need to know about using them. Whether you treat patients, maybe you're a provider, or maybe you're thinking about using these themselves, or you're just curious about them. Could they be good for me? Could they be good for someone I know? This episode gives you the science and the practical takeaways that I hope you learn some stuff from. So what is GLP-1? What does that stand for? It's glucagon-like peptide-1. It's created in the body naturally. It's an insertin hormone released from the gut after you eat. So it's in the lining of the gut, of your stomach, of your gut. Once you eat and you start the digestive process, it releases this hormone. And it enhances glucose-dependent insulin secretions. So it suppresses glucagon, slows gastric emptying, and reduces appetite. And that's a good recipe for helping people digest their food, keep blood glucose levels good, lowering A1C, and eating less. And when you do those four things, you tend to lose weight. It's a great side effect. And we'll get into the story later. Physiological mechanism, if you're wondering how this works in the nitty-gritty, they're secreted from intestinal L cells in response to nutrients, like endogenous GLP-1 acts on GLP-1 receptors in the pancreas to increase insulin only when glucose is elevated. So for those of us that are insulin sensitive, this helps because it tells the pancreas, hey, we're nudging you here. Don't slack on the insulin, because over time, as we live with higher glucose levels in the blood, our pancreas starts to get lethargic. It gets fatigued, it gets tired, and then it's a little bit less receptive to glucose. And so it's like, do we really need to pump and inject insulin? I've been doing this for 48 years. Do I really need to keep pumping every time you eat a meal? What's up with you and your jellies and marmalades on your toast, man? Like, come on, why do I got to do this every morning, right? So that's what's going on with the pancreas. So it increases it, makes it more sensitive. It says, yeah, man, you got to do it. It's like a personal trainer for your pancreas. Like, come on, do it, do your job. And it does it, but only when it's elevated. So we get better control. That glucose dependence reduces hypoglycemia risk compared with other older drugs that we use for maybe diabetes or pre-diabetes that would just inject insulin into the body. And when you do that, you got to monitor the glucose levels. And if we do too much insulin, it will lower blood glucose to a hypoglycemic level, which can make people faint, pass out, and those things. So this has been better at doing that for pre-diabetic patients, not for strictly diabetic patients. It also suppresses glucagon release and slows gastric emptying, which helps reduce post-meal glucose spikes and increase satiety, increases your feeling full. So pharmaceutical GLP-1 receptor agonists, exenatide, liraglutide, semaglutide, all these ones are modified to last longer in the body so they can be dosed daily or weekly and achieve sustained effects on appetite and glycemic control. Okay, there you go. That's the physiological mechanism. All receptors in the gut and the pancreas to help control glucose levels in the body by controlling good output of insulin. There you go. That's a summary of the physiology. How do GLP-1s alter the brain and behavior? This is stuff people don't talk about. We talk about the physiology. We talk about what they do, suppress appetite, helps empty the gut, helps do all this stuff, and helps you eat less and you lose weight. And everyone's, I'll take it. I'll buy it. How much is it? $600 a month? I'll do it. And they do it. But the truth is what is it doing to your brain? If we're going to talk about hormone receptors, binding and competing for receptor sites in the body, you have to involve the brain. The brain is going to get involved with this. So GLP-1 receptors are present in multiple brain regions, not just one. Hypothalamus, your brainstem, your mesolimbic reward circuits, they're everywhere. So these GLP-1 receptors are back and forth. The gut-brain connection, we've talked about this many, many times. And this medication, this drug, this peptide is bringing it to the forefront because the world is using it. So I think we all should understand a little bit more. GLP-1 agonists reduce hunger signals affecting melanocortin or POMC and AGRP pathways in the brain. We won't get into that. That could be a whole hour about how those pathways work with appetite and how we digest food. But they reduce the hunger signals in the brain. So you just feel less hungry even after meals. And blunt reward-driven eating, it completely, people are like, I don't even care for the salty snacks in the evening. I don't care about my sweet tooth anymore. I don't care about that stuff. It lessens the wanting for high palatable foods. You lose that need to chew on the chewy gummy or to crunch the crunchy chip or the cracker. You lose it. All sounds good so far, right? Which together reduce caloric intake overall, reduces snacking, reduces all these things. And you can see how you build a lower calorie intake, which helps people lose weight. They also slow gastric emptying, sending stronger fullness signals from the gut to the brain. So even with smaller portions of meals, you feel satiated, you feel full. Those signals get to the brain. The brain's like, yeah, you ate enough. It's good. We're good. So there's a lot of stuff there. There's evolving evidence currently that GLP-1 agonists can alter craving/addiction circuits, which is why researchers are studying them for alcohol, nicotine, and other substance use disorders. Emerging area mechanisms still under studies, and that's from PMC. So there is more research going into it. They're using it for other things. And the short history of Ozempic, Wegovy, and why this matters is that Novo Nordisk's semaglutide was first FDA approved as Ozempic for type 2 diabetes officially in 2017. Later, a higher dose formulation marked as Wegovy was approved specifically for chronic weight management for obesity, people at 31% or higher BMIs in 2021. So it's Wegovy that has the obesity FDA approval and Ozempic that has the diabetic approval. The diabetes approval noted weight loss as an observed secondary benefit. Subsequent trials led to obesity-specific approval because it was secondary. So they were controlling blood sugar, A1C, and glucose as the drug better, longer lasting. It was as a better drug. And they were like, listen, people are losing a ton of weight, which makes sense. So now it's blown up for weight loss, but really, under insurance code, still in the United States, you have to be diagnosed with either diabetes, prediabetes, high A1C, or uncontrolled blood glucose levels, which is diabetes. So that is how you get it covered. Otherwise, if you don't fall into that bracket, it's out of pocket through the peptide ways. Other players like liraglutide, exenatide, and the newer dual GLP-1 agonists like tirzepatide expanded options. Tirzepatide showed very large weight loss effects in obesity trials for people 31% or higher in BMI, which accelerated public attention to these drugs. And that is the short history to it. Underlying studies, both in the United States, Canada, and Europe, are showing that the brain barriers that are being blocked for addictive personalities transcend across the brain through the midbrain and brainstem, showing that any type of behaviors can be suppressed. So we're seeing this as in libido being dropped, want overall, desire, going after the goal. You just see people kind of dull down a little bit the longer they use it. And that's what I wanted to highlight a little bit in this podcast is like long-term use of these things alters the brain. And you know my stance on the brain. It was designed perfectly, well beyond anything we understand by the universe or God, whatever you believe, and it is perfect. And if you keep messing with it, expect the side effects, expect other things to happen. Stop messing with your brains. And we're going to see this research down the road. So that's a little bit, and I don't have anything stamped on you. They're under it right now. They're showing it, and that's why we're getting into nicotine, alcohol studies, is because it is helping people kind of dull down their need and dependency for addictive behaviors. And eating and sugar and salt and all these things can be addictive as well. Sugar is more addictive than most drugs out there. So we know this. How do we use these properly? Let's get into the practical guidance of GLP-1s and the indications from the FDA approved way for, T2D, so various agents and chronic weight management in people meeting obesity criteria like BMI thresholds or BMI plus comorbidity for Wegovy. Use should be supervised by a clinician. That's what the FDA guidelines are. You should not be buying this on your own and dosing it on your own. Do not, because it has to be monitored with blood work and other things as well. The typical approach is to start low and titrate slowly to reduce GI side effects. Nausea is the most common. Weekly semaglutide injections have established titration schedules, and clinicians should follow the specific product label, and they will for you and based on your weight and height and what you've done in the past. There's some important principles to remember with GLP-1s. You got to pair medication with lifestyle changes. So diet, physical activity, and behavior support improve outcomes and are required for long-term success. The fundamentals can't go away. You can't just keep eating fast food and then go on a GLP-1 and say, I'm not losing that much weight. Why? Well, we have to change everything. Be mindful of other glucose-lowering drugs, and that's why clinicians have to be involved. If you're on metformin, insulin, or anything else, if a patient's on insulin or sulfonylurea, reduce doses as needed to avoid hypoglycemia, and that's what your doctor's going to do, right? So expect that weight trends to be regained if medication is stopped. It says it right on the label. Stop the medication, you're going to gain the weight back. You got to treat GLP-1 as a chronic therapy when indicated and plan follow-ups. So it's either hyperacute, used in like bodybuilding, athletics, or something like that to lower body fat percentage a little bit. They're using this. Do I condone it? Not so much. But if it's hyperacute, then your body won't get used to anything long-term, which I approve. Long-term use is where we run into these issues. Yes, you lose the 45 pounds over the course of 12 months. And then what happens when you get off of this? Well, those receptors start to awaken again. What's going to happen with that? Do we fall back into old habits, which humans typically do? Or have we learned enough new skills to maintain that weight? Could be. But unfortunately, it's like 90% fall back, 10% or less maintain. Main risks and safety signals. So please listen to this if you're on it or you're thinking about it. These are the things I want you to walk away with today. Common and expected side effects. These are listed right on the vial. Nausea, vomiting, constipation, diarrhea, early satiety, and sometimes transient dizziness. These are usually worse during dose escalation because you're just going to naturally not want food and eat less, and your body's probably not used to that. Now we get into some crazy stuff. Pancreatitis. Yes, we're blocking receptors in the pancreas, which can make it more inflamed because it'll back up other hormone pathways in there as well. Rare, but they are reported. Pancreatitis, patients with severe abdominal pain should stop therapy and be evaluated immediately. There should be no pain with this. Hunger pangs, okay, but no organ pain. Gallbladder disease, rapid weight loss, and GLP-1 use are associated with gallbladder events like cholestasis, which is gallbladder stones. It can happen because you burn a lot of fat. Your liver now has to metabolize all that, the fat loss that's happening. There's a metabolism process to that as well. Your liver plays a role in that. So all those extra triglycerides being broken down, great for fat loss, but can back up the gallbladder a little bit too. So that's reported in some cases. Thyroid C-cell tumors. So it's a boxed warning. Semaglutide has been boxed warning based on rodent studies showing medullary thyroid carcinoma. Human relevance is unclear, but semaglutide is contraindicated in people with a personal, family, or history of medullary thyroid carcinoma or M2 syndromes. This is an important and prominent safety label item. Kidney injuries. Cause of acute kidney injuries have been reported often related to dehydration from GI side effects. Monitor renal function, especially in at-risk patients. So if you've got renal issues, think twice about starting this. Unapproved/compounded products. That's probably the biggest thing we're running into in the United States with all the compounding pharmacies that have been allowed to do this. You could use a reputable pharmacy that has a good track record, and hopefully your clinician is doing that for you. The FDA has warned about unapproved compounded GLP-1 products and direct-to-consumer vials that may be unsafe or mislabeled. Patients should avoid purchasing or using unapproved formulations. My biggest advice from what I'm seeing, if you see anything super cheap, stay away from it. $59 a month, $100 a month. There's no way a compounding pharmacy can get it or make it for that cheap. So if you're seeing that, you're probably getting something not good. So be careful on that. And your clinician may or may not know that. Probably not if they're giving it to you. No one out there wants to hurt other people and just make money. Right? Right? Not America. No way. Monitoring and red flags. Baseline weight, your baseline weight, your A1C if you're diabetic. I just check it on everyone, A1C. Renal function, medication list, thyroid/history or family history, and then counsel about GI side effects and when to seek care is what you should see on your first appointment with any clinician you're doing this. So that's what they should be asking for. They should be sending you for new blood work, not using your old blood work. They can't because things change. Have to see something new or recent. Monitor for persistent severe GI symptoms. That's your job. If anything feels weird, email them, text them, call them immediately, your provider. Say, listen, I feel like this. Severe abdominal pain, that's pancreatitis. We talked about that. Jaundice or signs of cholecystitis, gallbladder. New thyroid nodules by palpating your throat if you feel any nodules in there that are getting bigger or anything, or symptoms that are suggestive of thyroid disease. Review other glucose medications to avoid hypoglycemia, and that's your clinician's job. So broader considerations about GLP-1s, access, ethics, and how we're using them right now. It's all vanity, of course. That's how the world is right now. It's all about how we look instead of how we actually function, which I get. It's supply and access is the issue right now. So high demand has strained supplies in past years. There are ethical concerns when people without diabetes obtain GLP-1s for weight loss, while patients with diabetes may face issues. We saw that in 2024. People with diabetes were not getting the drug, not just because of insurance denial, but because the drug was back ordered. Now, that's a problem. You're taking something, it's like almost like sweeping the shelves off of antibiotics, taking all the antibiotics off the shelf and bringing them home and be like, I'm going to save these for when my family needs it. And then someone walks in right after you 10 minutes later with a kid with an ear infection and there's no antibiotics. That's insane. That's crazy that we're allowing that. But in America, we wouldn't put money over people, would we? Or harm them, right? right? Yeah. Cost and insurance. Many insurers cover GLP-1s for diabetes. Coverage for obesity indications varies and can be limited. And cost can be a barrier too. These drugs aren't cheap. The only way to get them approved is to be diagnosed by a medical doctor, your primary physician, that can diagnose you for that diabetes, and that this would be a good drug to help you. Then you can get most of it, if not all of it, covered by insurance. Body image and expectations, maintain realistic expectations. What I tell all my patients, be realistic. I will see men and women in their 50s and 60s. I ask them, what's their goal weight? And they'll tell me their goal weight. I say, when was the last time you were like that? And they're like, oh, 21, like literally college. And I'm like, really? You really think you can get back to college weight? They're like, why not? I should be able to do it. I know why I'm in this position in the first place. No, you can't get back to 21. I'm sorry. I'm just being completely realistic with you. And if you do, you're going to hurt yourself. You're going to actually drop a bunch of lean muscle mass to get to that number on the scale, and then be worse off than if you were 139 versus 121 pounds when you were 21. I don't get it. So for clinicians and for patients listening, GLP-1 receptor agonists are powerful tools for glycemic control and weight loss, and used appropriately under medical supervision. They work with pancreatic effects by changing gut-brain signaling to reduce appetite and food reward. But they have side effects and important safety considerations. Use appropriate screening, titration, and follow-ups to make these things work for you the best way possible. So, a couple things. Patient story, that we had a while. Someone who used the GLP-1 under medical care, and in our office we have our functional medical program that from two different doctors that are doing it and getting results. Patients do see the results. It makes it easier when you lose that appetite. It just makes it easier to do that. We can't mistake GLP-1s for fat burners. They're not fat burners. What they do is help with absorption, help with emptying for absorption, and signal receptors from the gut to the brain about being full or not. That's just really it. They're blood glucose regulators by influencing the pancreas. They're not fat burners. They're not like increasing heart rate or caffeine or adrenaline or some of those supplements you take to increase basal metabolic rate, which are also dangerous in themselves, which are supposed to stimulate metabolism for burning fat. They're not that. So by taking that in the bodybuilding world, I just don't know what they're thinking, because it's not really promoting that. It's really promoting their gut. And these people that are that athletic are already eating well. They're on like a program of food. So interesting to see what the results are for them. Does Ozempic cause everyone to lose muscle? Myth or fact? That was that question that came up and actually spurred me to do this episode. Is it safe if I have a kidney disease? Those are two things too. So number one, does Ozempic cause everyone to lose muscle? If you keep doing what you're doing today and you keep moving forward, and 30 days from now, you book an appointment and you meet with a clinician and you're put on GLP-1, semaglutide, let's say, or tirzepatide, and you start using that and you continue living the exact same life, no real changes, will you lose muscle mass? The answer is yes. The only way to counteract that, because your calories are going to go down, your eating is going to go down, and your will to do stuff is going to go down. You're just going to kind of be taken down a little bit. You'll be like, I don't care. I don't care about watching that movie. I don't care about having sex. I don't care about, I just don't care. It's all going to go down. So if we don't start working out or start doing some resistance training to offset the lower calorie, our muscles are going to break down for protein use. So yes, the answer is yes. So we saw this Ozempic face, Ozempic butt. People are losing their glutes. They're losing their muscles in their face because they just haven't done anything. They never did go to the gym and start GLP-1s, and they never started going to the gym. They just continued living their life working at a desk, taking that, losing the weight, but the weight's coming off everywhere. So the biggest thing we're seeing, and we do red light in the office, is skin. More people are coming in for like skin tightening than ever before. They're like, I lost all this weight. I got to tighten the skin. And the real answer to that dramatic weight loss stuff is there's no light in the world or machine in the world that's going to really tighten the skin enough to make a dramatic improvement. That's going to require liposuction and plastic surgery. It really the only way to do that. So because of the fast weight loss there. So those are some myths. Is it safe if I have kidney disease? The fundamental answer is no. It's not safe. If you have any type of kidney disease, should be supervised by a clinician. And if a clinician is going to start you, I'd be a little weary if you had kidney disease and someone said, yeah, go ahead, you can use GLP-1s. So no, I would say no. That's it. If you are considering GLP-1s for you, or you know someone in your family that is, talk to a clinician first, make sure they're reputable, check your medical history. The biggest things are thyroid cancer and a family history of it, and plan for slow dose escalation. And that's typically how all clinicians will start you, and discuss other diabetes meds, if applicable, if you're diabetic, and commit to lifestyle support. Avoid purchasing unapproved compound products online for a cheaper price. Don't do that. Always do it through your clinician. And you should be pretty safe there. What a world we live in. This is the stuff we're talking about now. One of the most popular things. Look at it. Go and Google search how much Ozempic has made. Is it Denmark or Norway? I'm pretty sure it's Denmark. Go and look what it's done. Like, it's just unbelievable. I think they're all driving Ferraris in Denmark now. I'm just giving people Ferrari checks. Like, it's crazy. Or whatever their sports car is in Denmark. Do they make cars? I don't think so. They're not as cool as the Italians. But that's your podcast for the week. GLP-1s, weight loss. We'll do a whole weight loss series again. Healthy stuff, foods. We've done diet stuff. You can go back and search in our Living a Full Life. Can you believe this is episode number 52 of our third season? So this has been 3 years of continuous podcasts every single Tuesday for you and your families. I'm not bragging. I'm just telling you it's not going to stop. We're just going to keep going, keeping you up to loop. If you have any questions, this is how I build podcasts. So if you're wondering how I come up with all these ideas and how I can just talk for 20 minutes every week, it's really, I do my research first on your questions, and I build podcasts around that. So they're relevant. That's why we have listeners. Stay well, stay healthy, take care, and have a great week.
Thanks so much for tuning into this episode of Living a Full Life podcast. If you're enjoying the show, please feel free to rate, subscribe, and leave a review wherever you listen to your podcasts. That helps others find the show, and we greatly appreciate it. Thanks again for tuning in, and we'll catch you in the next episode.